Good afternoon, everyone. Welcome back to the second hour of molecular signaling. And I see here more people start to show up for the second hour, which is very enjoyable, by the way. It's now 1 o'clock p.m. U.S. Eastern Time, and I'm Dr. Henry Zeidan. You have my website here, so you can have all the contact information. And I went over my biovita in the first lecture of pharmacology that you have it on YouTube. All of those lectures also will be uploaded in my website. Let's go and briefly enjoy this chess game approach. What we covered so far, as I stated to you in the first hour, we covered nuclear receptor mechanisms. We understand the function of steroid hormones, the function of drugs that can act on a similar manner, like dexamethasone versus hydrocortisone, and how they function as a common anti-inflammatory agents. We covered ion channels and address classes that deals with receptor bind to sodium ion channel or chloride ion channel in terms of diazepine, in terms of function of common antidepressant agents, in terms of nicotinic receptors that you're going to see them abundant in parasympathetic and sympathetic nervous system, acetylcholine, muscarinic receptors, and at the end you have a decent summary for all of that. At the end of the second hour, we covered G protein, GS and GI, coupled with cyclic AMP, coupled with protein kinase A. We covered phospholipase C and protein kinase C, mechanism of actions of those drugs being covered to you thoroughly. And last but not least, we covered how drugs function as inhibitors for specific enzymes, and we addressed several classes of enzymes that deal with this pattern. So that's what we covered in the first hour, and we ended up this actually by addressing the function of lithium as a common anti-bipolar agent that tends to inhibit dephosphorylation reaction of IP2 here to give you inositol. So in essence, it interferes with the recycling process of phosphatidyl inositol diphosphate. We covered also GMP, and we talked about vasodilation effect. We covered all of that in 1 hour. Let's shift the gears here and enjoy receptors that function as transmembrane enzymes. And the best example for that is tyrosine kinase, essentially. Tyrosine kinase actually forms a channel across the membrane, and it has 4 polypeptides, 2 alpha and 2 beta, and they link it together in this fashion. So tyrosine kinase will tend to be phosphorylated, okay, and in this essence, as I said, insulin function in this mechanism. Insulin function on tyrosine kinase enzyme, and you're dealing here with activation of proteins at a cellular level that tends to modify gene transcription. So in essence, you don't see here a coupling reaction with cyclic AMP or cyclic GMP or phospholipase C. The term coupling, you have coupled system, but here you see activation of proteins that can produce the effect. So this is nicely addressed here, 2-alpha and 2-beta, and when it binds. So you tend to cause conformational change, and you tend to phosphorylate the remaining domain intracellularly, and as a result of that, you activate this cascade of phosphorylation reaction. So it's nicely addressed in this fashion. See, it's nicely addressed in this fashion. You have also to keep in mind, as I stated, that insulin function as both as a hormone and also function as a drug for treatment of type 1 diabetes. Now, cytokines function in a similar manner. You have here a cascade of proteins involved. You have a direct activation at the molecular level, at the genetic level. Okay. And cytokines, drugs essentially function on those receptors, cytokine receptors. So you see that commonly in erythropoietin, you see that with alpha and gamma interferon, and they resemble very much the same as tyrosine kinase channels. They tend to phosphorylate signal transducer activator, STAT, that tends to modify gene transcription. This is a beautiful illustration here. Where do you see that? You see that with growth factor hormone. You see that with platelet growth factors hormones. And in fact, you can have actually a complex system between EGF and steroid hormone, or EGF and tyrosine kinase. But the bottom line is that you're dealing with activation of series of proteins here, RAS, RAF, MEK, okay, and that's Jan's kinases. So when you phosphorylate tyrosine kinase, you end up with phosphorylation of all of those proteins, and then at the genetic level you will end up with gene expression. That's what you see here. I will get back to the previous slide with some more elaboration, but in certain cases that can lead actually to breast cancer, prostate cancer, you're dealing with a mutation that takes place with certain activating proteins here. So you see here the growth factor receptor forms a channel, and in a normal procedure you see that activation of RAS proteins will activate at the genetic level transcription of DNA and the producing proteins for cell division. That's in the normal process. When you have a mutation that takes place, mutated RAS proteins, so you see actually losing control on DNA synthesis. Now let's go back to this beautiful illustration that you have it here. You have EGF, growth factor receptor, coupled with tyrosine kinase enzyme. You can see that here. Okay, let me get my pointer so you can see what I'm talking about. See, EGF at its receptor coupled with tyrosine kinase, and you're dealing with phosphorylation reactions. You're phosphorylating all of those proteins, so you're activating gene activation, cell cycle progression, and that's what you end up with here. Growth effects. What happened here when a mutation takes place, so you tend to overproduce DNA, you tend to have problems. So this beautiful illustration here showed you actually where STAT belongs to, where JAK belongs to, and this phosphorylation reaction cascade. Those two groups that I mentioned to you in my first hour, a group at Johns Hopkins University Cancer Center and University of Pennsylvania Cancer Center, they were able to develop those drugs that tends to interfere with the phosphorylation reaction to take place. And they use this as a mechanism for breast cancer that follows this mechanism, or prostate cancer that follows this mechanism. So the gefitinib and erlotinib act effectively here to block these phosphorylation reactions, along with other series of drugs. So this is what you have here, the proposed mechanism of action of EGFR targeted tyrosine kinase inhibitors. So this is what you saw in the previous slide. That's a mechanism of phosphorylation that deals with abundant, when you have a mutation, so you deal with abundant of DNA synthesis, you're dealing with tumor cell proliferation. So the whole idea here is to block this phosphorylation reaction to take place, and that's where you can put those GI at a rest stage, so you're not producing any of those signals to take place. This is a decent presentation you hear. So actually they did a marvelous job actually to have those drug genotype to act effectively on various sites, gefitinib and erlotinib, to act on those sites here. So erlotinib or gefitinib act on the site, so you cause no phosphorylation reactions take place at the site, and you stop actually the progression of tumor. So the use of tyrosine kinase inhibitor actually was effective in dealing with EGFR mutant tumors, and you can see here tremendous improvement. But the problem with that is acquired resistance that take place. So you're dealing with progression, acquired resistance, but they followed up by chemotherapy. So a combination of chemotherapy with TKI can be effective in this manner. And this work actually did start in 2006, 2007, and still continuing on this fashion. And you have here the outstanding presentation again to emphasize on the function of TKI inhibitors and the dephosphorylation reactions to take place and how they interfere with the STAT compounds. This is a nice presentation again for the use of anti-EGFR monoclonal antibody. With that, we completed all what we like to say about those molecular signaling mechanisms. Let's move on and highlight to you really where you're going to see that in terms of receptor specificity, and that will act as a bridge to address cholinergic and adrenergic drugs. So when we move on the cycle, we may or may not recover this. We may or may not cover this topic again. But here is a summary for what I like to address. So let's sort out those adrenergic receptors first and then move on to cholinergic receptors. When you deal with adrenergic receptors here, you're dealing with norepinephrine, epinephrine, and catecholamine neurotransmitters. That's what you're going to see in the sympathetic branch of autonomic nervous system. We already stated that those receptors are excellent example for G protein cyclic AMP receptors, the cascade that follow cyclic AMP. With respect to muscarinic receptors, you have 5 subtypes of muscarinic receptors: M1, M2, M3, M4, M5. M1, M3, and M5 are coupled with GQ. So what do you expect to see? Phospholipase activation. Here. See that? GQ type. So activate phospholipase C, activate protein kinase C. So you're dealing with calcium that act as a third messenger. On the other hand, M4 and M2 deal with GI, deal with inhibition of adenylyl cyclase. So to make the long story short, I listed to you here, I actually put it again for you as a reminder. You are dealing with adrenergic receptors here, muscarinic receptors. Okay. You're dealing with neurotransmitters that you're going to see in parasympathetic nervous system and sympathetic nervous system. You're dealing with coupling of ion channel sodium-potassium cotransporter. And we already addressed the function of Prozac, fluoxetine, as an effective antidepressant agent that tends to inhibit serotonin transporter. Good example for SSRI. Cocaine helps to build up serotonin. And in summary, you have this table here address that beautifully. As I stated to you before, you're dealing with receptor specificity here. That's a target for PNS. That's a target for cardiovascular system. That's a target for CNS. Two of the major classes that numerous medical students consider them tough ones. And normally the grades are not so high in those classes. That's when you deal with PNS and cardiovascular system. Why is that here? Because you're dealing with specificity requirement. There is no memorization involved here. It's rationalization. If you understand receptors, subtypes, specificity of certain drugs, alpha, beta drugs, beta blockers and stuff like that, you can sort out this. You can sort out function of agonist, antagonist, and you can relate that very nicely with the effect, side effects and stuff like that. So M1, M3, and alpha 1, they all follow GQ. They all follow protein kinase C. They all follow production of a second messenger as inositol triphosphate and diacylglycerol. Beta receptors, dopamine receptors, on the other hand, follow GS, coupling protein, follow production of cyclic AMP, follow activation of adenylyl cyclase, follow production of calcium as a second messenger. So here you're dealing with activation of GS coupled system. Alpha 1, M2, muscarinic receptor M2, follow GI. So you're dealing with inhibition of adenylyl cyclase. You're dealing with decreased production of cyclic AMP. You're dealing with decreased calcium influx and adenylyl cyclase and activation of potassium. Keep in mind, all of those are coupled reactions here. Why? Because you're coupling with G proteins. Those are different from ion channels, that where you don't see this coupling, but the receptor is linked to ion channel. Can pass sodium down gradient, so you're causing depolarization to take place, or it can pass chlorine ions to move down gradient, and you're causing hypopolarization reactions, right? Like GABA. Okay. With depolarization reactions, you see that in construction, conservative agents here. So with that, we very much addressed this information. I listed here to you the references that you can look at along with the websites. With that, we completed essentially molecular signaling from a pharmacological point of view. And please, please, please keep in mind that when you deal with molecular signaling from a pharmacology point of view, you're talking about the same language as when we talk about hormonal aspects. So we're addressing in different direction here. Okay, we like to understand this beautiful system and keep in mind that certain drugs actually do function as hormones as well. Okay. So with that said, I completed my presentation for this system, and we should be able to move on to address classes. Let me see here if I have yeah, if you have any question before I leave, you're welcome to address it to me. Still have a few minutes. Otherwise, I will finish early, and I will send you another announcement for the next activities. Please, yeah, okay, just a minute. Thank you. So thank you for a great presentation. Yeah, please, before I leave, I like to receive your comments. Email it to me, please. Email me your comments about the webinar as soon as you can. I send it to everyone here. So please do that. And I hope you're enjoying pharmacology, and you're going to enjoy it more and more as we proceed on. Thank you, Anna. Thank you very much. Thank you. Thank you. I appreciate it, everyone, and look forward for my next announcement. And I'm going to actually give a talk and place it on YouTube, so for additional introduction and how we like to proceed. But keep in mind, I'm here actually to help you, and I will find every way to assist you in that. And the fortunate situation about it, because I enjoy the material. I enjoy actually teaching pharmacology, and I enjoy teaching endocrine physiology, and I enjoy teaching biochemistry. And I can look at the big picture, and I want you to enjoy it with me as well. And you're going to love it. Thank you all. Thank you all, and see you soon. Have a great day now. Bye-bye. You're very welcome. You're very welcome.